Good afternoon, everyone. On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Bloodless Medicine, Cultural Competency to Address the Needs of Jehovah's Witness Patients. My name is Shirley Dominic, and I will be your moderator for this program. Now I'd like to introduce our speakers for this webinar. Dr. Patricia Ford is an Associate Clinical Professor at the University of Pennsylvania School of Medicine and a member of the medical staff at Pennsylvania Hospital in the Division of Hematology and Oncology. She serves as Medical Director of the Center for Transfusion-Free Medicine, the Clinical Research Unit, and the Autologous Transplant Program, where she led the world's first and largest series of bloodless transplants for Jehovah's Witnesses. Our second speaker, Joseph Riddick, has 24 years at the Center for Transfusion-Free Medicine and brings deep expertise and a strong commitment to patient-centered care. As lead coordinator, he educates, advocates, and serves as a key link between patients and the clinical team, ensuring personalized, transfusion-free care aligned with each patient's needs and beliefs. Dr. Patricia Ford, planner and speaker for this educational event, is a medical advisor for Acumen. All relevant financial relationships have been mitigated. None of the remaining planners or presenters for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And with that, I will turn the presentation over to you, Dr. Ford.
Thank you very much, Shirley, and to the organizers for this opportunity to share some of the information on our program. So I'm going to be presenting Bloodless Medicine, Cultural Competency to Address the Needs of Jehovah's Witness Patients, along with Joseph Riddick. To review our objectives, we'd like to really define culture and cultural competency in healthcare with an emphasis on how this applies to our transfusion-free medicine patients. And you may hear that also referred to as bloodless medicine. They're synonymous. And in our program, about 95% of our patients are Jehovah's Witnesses, but about 5% are patients who decline transfusions for other reasons. So we're going to describe the belief and needs of the Jehovah's Witness population, and we're going to explain how our Center for Transfusion-Free Medicine supports cultural competency care. So what is culture? Culture is the customary beliefs, social forms, and material traits of a racial, religious, or social group. What is cultural competence? Cultural competence is understanding, communicating with, and effectively interacting with people across all cultures and religious beliefs. And in relation to us as healthcare providers, it's the ability of a system to provide care to patients with diverse values, beliefs, and behaviors, and then for us to tailor the delivery to meet their social, cultural, and linguistic needs. A lot of what we'll be talking about will just highlight how to build trust and adapting care, and this will allow us to provide essential strategies to reduce healthcare disparities and hopefully improve our patient satisfaction. Now, the importance of cultural competency in bloodless medicine or transfusion-free medicine highlights the following. Patient safety prevents harmful errors like administering blood products against a patient's wishes. The legal and ethical compliance, this protects the legal right of competent adults to have informed refusal and supports ethical practice. For trust and satisfaction, we hope we build strong provider-patient relationships, and we encourage patients to seek care without fear or discrimination. For equity, respectful care for all individuals, regardless of their background or belief, is what we strive to provide. So I'm going to turn this over now to Joseph Riddick for the next section.
Thank you, Dr. Ford. I'd like to begin by highlighting why would a patient refuse a blood transfusion. When it comes to, the next slide please, when it comes to the religious position for Jehovah's Witnesses, the patient of Jehovah's Witnesses are declining a blood transfusion based on the biblical passage that's found at Acts chapter 15, verse 20, chapter 15, verses 19 and 20. This is a scripture that drives the reason why Jehovah's Witnesses decline of blood transfusion, because you notice that it says there that you should abstain from the use of blood. There's also individuals that would refuse a blood transfusion for personal reasons, whether it's for reservations of donor blood or lack of trust, or even some reasons for science and political reasons. There's multiple reasons, but for the most part, we're talking about Jehovah's Witness community. Is again, that position to refuse blood is based on scriptural principles or laws that's found in the Bible. When it comes to understanding the Jehovah's Witness patient, we like to highlight the importance that Jehovah's Witnesses are not anti-medicine. They are individuals that love life and they seek out quality care in regards to healthcare management. They accept the vast majority of medical procedures that would be very instrumental and very advantageous for their medical care. Jehovah's Witness position on blood is really important that we have a discussion surrounding the dialogue or the position of Jehovah's Witnesses when it comes to blood. It's important to understand exactly what bloodless medicine or bloodless patients, what they're agreeable to and what they're not agreeable to. So when it comes to the various different terms, for instance, when it comes to whole blood, as we know, whole blood has various different components: red cells, white cells, platelets, and plasma. So the witness community makes it very clear that their position on declining blood is making reference to refusing red cells, white cells, platelets, and plasma. However, on the other hand, there are items known as derivatives of blood, or in the witness community, they look at these as fractions of blood. So the Jehovah's Witness could be agreeable to the use of the following items that's listed there. We'll be talking more about that as we move forward in our presentation, but these are items that are separate from blood, and they don't so clearly define violation of God's law. So therefore, many of the witness patients are inclined to accept the blood derivatives. What service do the Center for Transfusion Medicine provide for our team? Well, there's two factors to that. There's the administrative part. Coordinators like myself, we educate patients on non-blood management options, and we help them to document their choices in regards to what they're refusing. And we act as a patient advocate for our patients. The other piece is the clinical piece. The other side of it, I should say, is the clinical piece, where doctors and providers like Dr. Patricia Ford works as medical consults for our patients. They do hematology consults to provide excellent or effective treatment for our patients. And other recommendations on the clinical piece is where doctors and providers accept the idea, they give attention to agents to reverse anticoagulations and strategies to control ongoing bleeding. So these are various different clinical approaches that would help with patients that are declining the blood transfusion. We would like to also highlight the very fine safety feature when it comes to identifying properly for a transfusion-free medicine patient. We would like to see here, it shows here, when it comes to identifying the identification process, patients are identified as transfusion-free. That means that the patient states that they would refuse a blood transfusion. Again, these are patients that is clearly indicating under no circumstances what blood should be administered to them, so they're identified properly. The next step is the call comes into the Center for Transfusion-Free Medicine. That is a 24-hour line, so we're always available to take calls for patients that are calling in or providers that are calling in to help identify patients that are part of the Transfusion-Free Medicine patient program. Consultation is another key part of the process in identifying these patients properly. The coordinators will assess the patient's wishes, educate them, their options, and document them in the medical record system too, so other providers can be very clear in understanding what the patient is, what the patient position is. We also want to highlight the importance of identifiers and documentation. The patient is banned and quality indicators are put in place, and forms are scanned into the EMM system to identify these patients as transfusion-free medicine patients. So those are various different identifiers that we have in place. Our next slide talks further about that. And on our next slide, this is another identifier that we have in place to help identify transfusion-free medicine patients. This is what we know as the Advanced Medical Directive Release Form that we have. This form is an itemized list of all the minor blood fractions and medical devices that our program coordinators educate or go over with the patient as they're a patient here in the hospital. But the Center for Transfusion Medicine team is the ones that help complete this form. And also clinical staff will use this form to determine exactly what is it that the patient's agreeable to, what they're not. We have additional safety identifiers. These safety identifiers serve to be very effective when it comes to really protecting the needs of our patients that are declining blood. The identification wristband is designed to indicate again that the patient is refusing red cells, white cells, platelets, and plasma. And that identification band even have the department telephone number on it to do a consult with us or keep us involved in the patient's care as well. Another fine identifier is the bed sign. We have bed signs that are placed that identifies our department, and it clearly indicates the patient's refusing, again, the primary components, the red cells, white cell, platelets, and plasma. And that identifier also have our telephone number on it to keep us in the process as well. We have also what's known as our flags in the electronic chart. We alert the staff that patients are refusing a blood transfusion. There are there's flags that indicate that the patient has a position to decline blood. And we also have an identifier in place, which is the progress note. The progress note alerts the providers as to what the patient's position is. It emphasizes the patient is refusing a blood transfusion, as well as the alternative methods that the patient has agreed to be utilized in their behalf. Here's another fine safety factor that's in place. This particular double power of attorney is in the witness community, they look at this as known to have this as a DPA. This DPA document, indicates the patient will refuse a blood transfusion. It clearly states on the form that the patient's declining red cells, white cells, platelets, and plasma. The form is also designed to appoint healthcare agents to speak on the patient's behalf if the patient's in a position to not be able to speak for himself. So again, this is a form that's provided in the Christian Congregation of Jehovah's Witnesses. Once they've made it very clear that it is their desire to decline blood transfusion, this form is encouraged to be executed and to keep in their possession at all times, because it serves to prove to be a valuable resource for providers when the patient's unable to speak for themselves. There's additional service in place for the witness community. This particular slide highlights how the Jehovah's Witness community have various different resources involved. The Hospital Information Service, this is a service that is established to provide training to hospital liaison members, because the next feature is the hospital liaison members or committee. There are members from the Jehovah's Witness community that has volunteered their service to work on behalf of Jehovah's Witnesses to assist them to finding doctors and assist them to finding facilities that will practice non-blood management. The other service that's available for Jehovah's Witnesses is called the Patient Visitation Group, PVG. This is a pastoral service arrangement where patients, when they're in the hospital, members from the community volunteer their service to come in and visit patients to offer some additional spiritual support and to continue to work with and encourage them as they have a hospital stay. We also have what's known as the physician attestation list. This is a list of dedicated providers that has agreed to respect the wishes and treat the patients without the use of blood. The Transfusion-Free Medicine program meets with these providers one-on-one to determine their comfort level and to address their concerns and answer their questions when it comes to working or treating Jehovah's Witnesses. Our patients take delight in knowing that the Center for Transfusion Medicine program provides us such a list, a referral list of dedicated physicians that has been very much on board in treating them. We're happy to know that we also have the buy-in of leadership in supporting our arrangements here with the Transfusion-Free Medicine program. We also have what's known as the Community Outreach and Education Resource for our patients. This is an arrangement that we have put in place to help continue to support the population of patients that we have. We have monthly sessions that covers various different topics, whether it's heart health, skin cancer, GI bleeds, stroke awareness. We have these educational sessions are designed to really keep our community involved and to continue to educate our community on various different topics and subjects they are interested in. We also have educational outreaches that would surround workshops like the DPA workshop, a workshop that we have put in place to help continue to educate our patients and reminding them to the importance of their double power of attorney. And we usually have an attendance of anywhere from 75 or more for those particular programs. I'd like to direct your attention back to Dr. Ford.
Thank you. So I'd like to now talk a little bit about caring for the Jehovah Witness patient from the physician or provider perspective, kind of share some patients that I've encountered, and then as a non-Jehovah Witness, how I started this program and how I decided that I would be able to care for these patients. So taking you back to the beginning, when I first joined as a new attending out of fellowship, it was with my current partners to set up an autologous bone marrow transplant program. So that was also what I was doing, aligning with being a regular general hematologist oncologist. So I was about 1 year out of fellowship as an attending when one of the leaders of the Jehovah Witness community approached the hospital I was working at and asked if the hospital would be willing to care for the Jehovah Witnesses in our tri-state area, of which they estimated there could be about as many as 70,000 Jehovah Witnesses. And the hospital said, yes, of course, they would be open to caring for this population, but really felt like they needed to identify a physician leader. So they came to our group, and as I was one of the junior attendings, our group decided this might be a nice opportunity for me. I had a little bit more time than the other senior attendings to take on this program. So at that point, I first, before making the ultimate decision, said, can I accept possible death that might be preventable with treatment, which means blood transfusions in this case? And I then started wanting to know a little bit more about Jehovah Witness beliefs. So I spoke to the HLC in our area to learn more about their religion, their belief system. And then I realized, yes, this is something I think is very important, and I would very much like to do this because I do believe in the autonomy of a competent adult for decision making and very much importance of individual faith. I would want someone to be respectful of my decisions, my faith, should that come into question in terms of healthcare. So how could I handle this challenge? Well, first of all, I knew that I needed to do a lot of self-learning on how to care for patients without the ability to deliver blood products. So at that point, there really was no setup here in the United States, but I did find in Europe, they did have an organization looking at caring for Jehovah Witnesses. And I traveled over to Germany and spent some time there learning from the anesthesiology team, the surgeons, the hematologists, as to what might be some safe alternatives to utilize and what strategies could be implemented to prevent excessive blood loss. And I had a lot of support, not just from my colleagues, but also from administration. So fast forward about 1 year. So now I've been taking care of Jehovah Witnesses and have been dealing, like Joseph mentioned, with upper GI bleeds, with postpartum hemorrhage, with low blood counts, using a lot of growth factor support, a lot of iron, a lot of reversal of, blood thinners, a lot of expertise in that area. My surgery and anesthesia team were very good at utilizing all the strategies intraoperatively to minimize blood loss, which includes things like cell salvage and other techniques. And it was about a year into this when we had a patient in our practice who was a 30-year-old gentleman who is one of Jehovah Witnesses, and he had non-Hodgkin's lymphoma that was continuously recurring. My partner would get him into a remission, and that would only last for a couple months. He would recur, and we were running out of standard salvage chemotherapy options. And the disease was widespread throughout the liver, the kidney, and the lung, and rapid regrowth in between each of the different regimens that was being utilized. So the standard of care at this point for anyone would be to do an autologous bone marrow transplant for the only chance of a curative potential, or at least long-term disease-free survival. So my partner came to me and said, gee, would you be willing to, do a stem cell transplant on this individual without blood product support? And back then we were doing kind of PubMed searches. I tried to do a quick literature search and realized there was nothing published in anyone ever having tried to do this before. So then the next thing I did was look at, well, how many transfusions should I anticipate would be given to an autologous transplant patient? And remember, this was about 25 years ago. And back then, they would transfuse automatically just based on a number. If your hemoglobin was under an 8 or a 9, or the platelets were under 10 or 20, they would give you 1 or 2 units of blood and 6 units back then of platelets. So the average per patient was anywhere from 5 to 20 units, a big range. So then the next step I had to really consider was, is a stem cell transplant procedure acceptable for Jehovah Witnesses? So I took a visit to the Watchtower, which is the headquarters where the leaders are in the Jehovah Witness population, and we went through the whole process. Anything that has to do with a blood cell or a blood cell fraction. So I had to review with them. The first step when I collect cells is that I put them on an apheresis machine, and that is acceptable. Blood can be let from the body as long as it's in a continuous circuit. And then we collect these stem cells, and we also collect plasma. Plasma, what we were using is the storage media for those cells to be stored before we give them back. And at that point, the Watchtower said, we agree with everything. They can take stem cells. That would be acceptable. If you remember from one of Joseph's slides, the 4 products that cannot be given are white cells, red cells, platelets, and plasma. So white cells, yes, I'm given a type of white cell. It's the CD34, but it's a fraction. So they felt that part would be acceptable. I shared with them the fact that there would be contaminating red cells and platelets that were thought to probably be dead, but I can't filter them all out. And they said that would be acceptable. I'm not giving it for nutritive, or that's not the sole purpose, and they're probably not live cells. So they felt that was okay. And then the next thing was the storage medium of plasma. And they said, no, you cannot do it at that point because now you're collecting off plasma and giving back plasma. So I kind of left very devastated that I wouldn't be able to provide this. And as I was driving home, I said, well, maybe there's some other storage media that I can utilize that would be acceptable. So I worked with our blood bank technician, and we decided, well, what is plasma? It's really just normal saline albumin. And we came up with a formula we thought would be adequate for a storage medium. And then I called Watchtower back, and they said, yes, if you're using just normal saline albumin, that is quite acceptable. So at that point, we needed to talk to the patient and talk to all our colleagues, recognizing this would likely be the first transplant being done worldwide. And I could not really say to the patient what the expected morbidity or mortality was going to be. I could only say that at this point, you have no other options. Your chance of cure is 0 at this point. And with transplant, if successful, it could be as high as a 50% curative potential. But I really don't know. I think I can do this without blood products with some of the strategies I've learned over the last year. I had to talk to my colleagues in the intensive care unit, the nurses that be providing care both in the outpatient and inpatient setting, so that they all knew that the patient was willing to do this. I went through IRB, the ethics committee. So all that was negotiated quite quickly within a couple of weeks. So we moved forward. Now, his pre-transplant hemoglobin was not only normal, but with erythropoietin and iron, I got it up to 14. So a very robust starting red cell count. And he had normal platelet number at that point because he had been about a month off of his last chemotherapy treatment. So I gave him full dose of transplant drugs. They're very high doses of 3 different drugs for lymphoma. And over the next couple of weeks, we watched the nadir occur. The hemoglobin went down 5 grams. So a hemoglobin 9 is, as you know, as providers, very easily tolerated. And the platelet count, even though it went down into the single digits, using my alternatives of vitamin K and also utilizing antifibrinolytics, tranexamic acid or aminocaproic acid, I had no bleeding or organ damage in this individual. In lieu of the platelet transfusion, the whole thought I had was we give platelets to enhance hemostasis to prevent spontaneous bleeding. What's another way to enhance hemostasis? And for me, that was vitamin K and antifibrinolytic agents. And he was discharged in a record time within 3 weeks, did extremely well. And indeed, he was cured. So we actually followed him for a couple of years, and we knew at that point, after 5 years, that he was fully cured, having been through this. He had no long-term or even significant short-term toxicity from the high-dose chemotherapy, and it was just amazing. We felt so good about this first patient. The whole team was excited. It was just wonderful. Second patient. So about 2 months after I did this first transplant, a patient who was a 21-year-old woman flew in from California, having heard that we did this, to our emergency room. She had relapsed Hodgkin's lymphoma similar, failed multiple treatments, and actually had no other option, was placed on hospice level care, but heard I was an expert in the field, which, as you can imagine, having done only one transplant, I was quite concerned that I was not an expert at all. I've only done one, and her hemoglobin to start much different than our hemoglobin of 14 with our first patient. She was starting around a 9. So discussed with her and informed consent, IRB approval through the ethics committee. She knew that this was a chance to offer her disease-free survival or cure rate up to 50%. And for me, it was, can I do this again? Was that first one just a fluke? Can it be repeated? Can another individual actually survive a stem cell transplant? But I felt she had no other option, so we moved forward with informed consent. Unfortunately, we had the opposite outcome here. By the time she even got to transplant, after collecting stem cells and more time off treatment, her hemoglobin was in the 7 range. Her platelet count was under the normal 150 to 98. The white count was very high from all the circulating lymphoma cells, and we gave her full dose BCG chemotherapy. And as expected, the nadir started happening around day 7 after the chemotherapy, and you can see the dramatic decrease in the hemoglobin. Our first gentleman declined about 5 grams, and you can see here she's already down to a 4 gram on day 7. White count was low, platelets were low, all expected, and then you start to anticipate engraftment or recovery of those cells somewhere around that 9th day, and you can see on day 8, the white cells were indeed, and they always are, the first cell line to recover, but unfortunately, there was not enough time for the hemoglobin or platelets to recover. She actually died from profound anemia and hypoxia at that point. And as you can imagine, all of us, the healthcare providers, were emotionally devastated. So I had to make the decision at that point, was it ethical to continue this work? Meaning, what mortality rate, chance of cure is acceptable? So I've only done 2 patients at this point, but I have a mortality rate of 50%, a chance of cure of 50%. And can healthcare providers refuse to give certain care once they've started a program? So it took a lot of cell searching and discussion with my colleagues, who said no matter what I decided, they would support me. But I decided at that point that I was going to close the transplant program because what I felt was an unacceptable mortality rate of 50%. So I had a call from the family. The husband and the parents actually called and asked if they could meet with me, and they actually flew back from California here to Philadelphia. And I thought it was mostly going to be just reviewing her case and going through everything. And I was obviously anxious about the upcoming family meeting, but it was the opposite. They actually came back to tell me they heard that I was closing the program. They wanted to tell me how much they appreciated what I attempted to do. They gave their daughter and their wife hopefulness, and which no one else had given, and that our whole team was extremely respectful. And they really asked me to reconsider my decision and to continue to treat others who might be in the same situation. So very much based on that family discussion, not all myself, talking to myself, talking to my colleagues, but based on that discussion, I did decide to continue on. And 25 years later, I've done well over 400 transplants, 200 of which have been Jehovah Witnesses. It is still the largest series worldwide. We just get better and better as we get experience, as things evolve in the transplant world with better antibiotics, better alternatives. And we've had no deaths since 2010. In the Jehovah Witness population going through high-dose chemotherapy. And our mortality rate at this point is the same as transfused patients. My bleeding events are the same because I now have 200 patients that are non-Jehovah Witnesses getting transfused, 200 that are not getting transfused, and the bleeding events are exactly the same. And I've also, looking back, see that I now transfuse 90% less products to my non-Jehovah Witness patient, using the same strategies that I use in my Jehovah Witness population. So what we've decided to do is to write down, develop, and put down all our pathways and protocols. I tend to get a couple of consults per week from the country or worldwide, as I'm considered an expert in this field of hematologic malignancies and transplant and Jehovah Witnesses. So we really decided this can't just all be in my head anymore, that we really, even though I've published We really need to develop pathways and protocols for many of the things we provide that we can share with other providers. This will help standardize care. It will improve clinical outcomes. We hope it will avoid errors. And we're doing this by developing GI pathways, orthopedic pathways, and we'll just continue on with other pathways. So I want to shift the focus a little bit and share with you some of the errors that have occurred in this patient population. As you all know, no matter how tight you have things, developed in a program, errors can happen. And at that point, you need to go back in and analyze and then hopefully set up some better strategies and protections so it won't occur again. So for this individual that was one of Jehovah's Witnesses refusing transfusion, he presented to the emergency room at night on a weekend on Coumadin or warfarin with a very high INR. So the standard of care at that point would be to reverse that with fresh frozen plasma. And if you remember, that is one of the 4 things that cannot ever be given to a Jehovah's Witness. So overnight, the resident did not reach out to any of the attendings, but asked the patient if they would accept plasma. Now, one thing, patients come in and they know they can't take blood, but they're not healthcare providers. So they also need to have things defined for them. And here's where the confusion started. The patient asked, is that a transfusion product? Because he wasn't sure. And the resident said it is, however, it's a minor fraction. And the patient then agreed to accept the plasma, understanding and believing that it was acceptable within their religion. One of Joseph's slides had shown the way Jehovah's Witnesses think about blood products is in terms of major and minor. We tend to think of things in terms of when we donate blood to the Red Cross, that's whole blood. And then once that blood is donated, we fractionate it. We fractionate it into red cells, sometimes platelets, sometimes cryoprecipitate, which we then are plasma, which then is fractionated more to cryoprecipitate to albumin, et cetera, et cetera. So we think of whole blood as the only major component. Everything else is a fraction. And that's where the confusion began with the communication. So at the next day, once that was found by us, the patient was given a plasma product. We obviously told the patient, and at that point, we called in a hospital liaison committee to come in and help with counseling and for the patient, just in terms of having received that product. And then we looked at, and that's what started us to update our identification band, which in the past had just identified this as a Jehovah's Witness patient. So now we have it spelled out. No platelets, plasma, red cells, or white cells, and continued and ongoing education with our community outreach. So patients are better educated, and all the time we're re-educating our providers, our APPs, our physicians, etc. So here you can see what our old band used to look at. It looked like it just said no blood. And then now what our new identification band where it clearly spells out no platelets, plasma, red cells, or white cells. And just another understanding that patients have a verbiage that is different from what we use. They tend to say major products or major components they're not allowed to take are those 4. Everything else is a minor. In terms of providers, we say whole blood is the only major component we collect. Everything else is a fraction. So the second event. So erythropoietin, so the components that we use here, as you know, there are many. From Epigen to Aranest. There are many different brand names now of the red cell growth factor, and most of them contain albumin as a carrier molecule. No provider is going to necessarily know that routinely, that there's a little component of a human product of albumin there. So it is on our list, and that is the role of our Jehovah's Witness coordinators like Joseph. They go through all this, so the provider does not have to. We have listed and we educate the patient, things like, the erythropoietin, would you accept it with that minor component? You're allowed to, but it is an individual choice. And then they'll do a checklist. 99% of the time, they will check off all the allowable fractions they're allowed to take, but occasionally someone will refuse one of those, and it's our job to kind of highlight that. So it was highlighted in our forms that this patient would not accept erythropoietin. So they presented to the emergency room, the CTFF team, Joseph and others, met with the patient. All the forms are filled out in terms of acceptable options, and they said they would refuse erythropoietin. However, the next day, the provider for anemia knew that the standard would be to give iron and erythropoietin. They put that in the treatment plan, and the patient did receive erythropoietin. So we realized at this point, our important takeaway here is, although we've filled out the forms, we've educated, we've counseled, we can't communicate to every single provider having access to that patient that can write orders, and they may not know where the forms are actually uploaded or if these forms even exist. So it's ongoing identification and communication and education with our staff. It was one of our nurses who actually identified this inconsistency and alerted us that the patient received erythropoietin, which of course we let the patient know that, why we think that happened, and then moving forward, it's a constant re-education. So our learning opportunities here is just, we realize we have to do more communication education, even though our program forms are completed. At this point, they were not reviewed before administering this treatment to the patient. So we needed to increase the awareness. Where are these forms? How can they easily be located? I'm sure it's similar for you with our Epic. There must be 1,000 different clicks you can make to get to different pieces within Epic. So we needed to have this in a spot. And we now have an alert also, just like you have an allergy alert. So when you open up the chart, there is an alert there that identifies this patient as one of Jehovah's Witnesses and to look to the media page to get their forms. So our opportunity here was re-education of the hospital staff, the patients, and better alert systems in our Epic chart. So I'm bringing this next one up as the following. This is a new therapy, is CAR T. So this is one of our immunotherapies. And because it does contain a subset of white cells, which are the T lymphocytes, that needed to be reviewed. So when this came forward as a new modality we'd be offered to patients, I went back and traveled to the Watchtower to review this whole process to make sure that this was going to be acceptable for us to offer. So the little cartoon on the right just highlights what happens here. Step number one is we have to collect the cells. That's an apheresis collection where the machine is set up just to collect off T lymphocytes. Those are the part of the immune system that we need to collect off. So the T lymphocytes, that's acceptable. It's an apheresis. Now, that needs to be stored in something also. So you need to make sure, because there's many different products and they're all stored differently. So you need to make sure it's not being stored with albumin and that the company knows to either filter that off or to collect that in a different way with normal saline and albumin. Once the cells these live cells are collected, they're sent off to the lab and they're genetically engineered. We went through that whole process of how they're genetically engineered. All that was felt to be acceptable. And then the next step that happens, the actual treatment, are these genetically engineered cells we give back to the patient, which goes in and starts the tumor cell kill. And those cells replicate. They can be lifelong or at least last for many years. It's a one and done type of therapy. So it is great that we're able to offer this. It's acceptable, but providers need to be aware that they really need to know, is there any plasma? How is this being manufactured and collected? And this is the safety event number 3 I wanted to review. So this is a Jehovah's Witness patient with ALL, acute lymphocytic leukemia, who was treated at one of our sister hospitals here within our health system. And they did not know to even think through, is there any human blood cell component in this that I need to be aware of? So they just went ahead and administered the CAR T product, being unaware of human components, and failed to obtain any informed consent from the patient. So the learning opportunities here specifically is for any new strategy. How are the products being manufactured and processed? Is there any component of a human cell that you need to be aware of in terms of manufacturing, processing, administration? And then you want to assure through the Watchtower that this is going to be acceptable to the Jehovah's Witness community. So we do have a very comprehensive patient blood management program in our hospital. And what this is utilizing all the strategies that are used in Jehovah's Witness patients for those patients who would like to minimize their transfusion exposure, and utilizing all the alternatives, but may be willing to take a blood transfusion in the event it is considered emergent or life-saving. So we manage anemia, especially in our surgical patient, just early identification, and optimize the hemoglobin before they go to surgery. We want to make sure that we have reversal agents and identify any bleeding or coagulation dysfunction before they go to surgery. And certainly we want to do blood conservation modalities intraoperatively and also on the floors. We want to minimize iatrogenic blood loss, which means all the phlebotomies that are done on our patients on a daily basis. We want to minimize the amount or the numbers that are done that may be unnecessary. And we certainly want this to be a patient-centered decision-making, knowing that there's alternatives. So we actually did a small little survey in our hospital of both providers ordering transfusions and patients. And when all done, we asked both the providers and the patients, what is the biggest risk factors related to blood transfusions, and were any alternatives discussed? Providers and patients all said no alternatives were discussed. And when the patients answered, even after a good informed consent, they all said hepatitis and HIV are the risk factors. Our blood supply has never been safer. There are so many other risk factors that needed to have been discussed that weren't. So there, again, another opportunity to do better informed consent for those patients who will accept blood products. So we then decided we're going to combine our blood utilization and our patient blood management committee into one, so that we're taking the blood product as it's entering into the hospital, which is our blood bank, our blood utilization. They are responsible for keeping us supplied with blood and the safety and the inventory, all the way to the providers who are ordering, administering, and watching for reactions. So this is a combination of a committee that looks at blood from entry into the hospital to when it's given to the patient. And you can see this is a multidisciplinary approach to patient care, and that's the committee that is also helping to develop all these different protocols and pathways and guidelines for our patients. So our layers of safety here is the entry point for our patient. We identify our patients right in registration or admissions or the emergency room. We want to catch them early, and then we have an opportunity to begin the counseling, education. As Joseph mentioned, his team is available 24/7, as are we, the hematologists caring for these patients. Ongoing education of our nurses, all of our providers, in conjunction with our Center for Transfusion-Free Medicine. And we hope that this increases our patient safety and just kind of highlights the importance of education and communication.
Okay, thank you so much, Dr. Ford and Joseph. We appreciate this informative information that you've provided. So that does conclude the slide presentation portion of our program. We'd like to begin our question and answer period. So looks like we have quite a few questions here. We'll start with the first one. Do you have an electronic stop for those specific products or fractions that a patient refuses? And is refusal consent scanned into Epic immediately?
So Joseph, I'm going to ask you to unmute along with me, because it may be one or both of us answering some of these questions. So this is part of what Joseph and his team does, and I'll let you comment on that first, Joseph.
Electronic stop we have was known in our system to their flags. They're flags to alert the provider that this is a transfusion-free medicine program. And the system is even set up in a way that they can put in a consult to get some additional outreach for the patient. So the electronic stop, hard stop, not necessarily hard stop to prevent a blood transfusion, but yes, additional flags and alerts that the patient has declining blood.
And as part of the consent or the advanced directive for the second part of the question, yes, it does say, and I may be paraphrasing a little bit, and this was developed also with legal counseling. As a competent adult, I release the hospital and physician or providers from any poor outcomes related to my refusal of blood products. So there is a refusal component in their advanced directive.
Thank you. Our next question is addressing some pediatric issues. So during an emergent pediatric hemorrhage situation, would the medical team not transfuse and allow a child to die? I'm assuming this would be if someone came in, you knew that they were a Jehovah's Witness, but there were no adults present.
So and I'll have Joseph to come in second on this to elaborate a little bit more. So we do have not a pediatric unit that's done over at CHOP in our facility, but we have the largest obstetrical unit in the Philadelphia region. So we have a lot of neonatal care, and those neonates are transfused. And we have never in 30 years had to go to court to get any kind of court injunction to allow us to transfuse because of the discussions that happened with Joseph and his team and the pediatricians and the obstetricians along with the parents. They know that we need as physicians to provide life-saving care to any minor, and that may vary differently state to state, how you define a minor, but yes, we would transfuse a minor. So Joseph, I'll let you elaborate a little bit more about how we handle that.
Sure. I think it's also important to indicate that the witness community, the parents of the witnesses or community, they understand that the law does give the physicians the right to transfuse minors. So they, of course, would prefer that not to happen, but they would lean to the direction of the healthcare provider to administer necessary treatment that they feel is necessary to sustain the child's life. But they would not want to give consent themselves for the child to be transfused.
And that is, we're synthesizing what it is an hour long discussion that occurs to really establish that trust with the parents that we will do everything we can to minimize or limit blood transfusions, but we are obligated to perform life-saving strategies. And like I said, we have never had to go to court.
Thank you. We have another question here. How is Watchtower using this to educate the wider Jehovah's Witness population? So I'm assuming this program as a whole that you offer, how is their collaboration with Watchtower and how they're educating their community?
So Joseph, did you want to take that? Yes.
Sure. I think one of my slides highlighted the services like the hospital information services. The hospital information service, again, is really a provision that's used to really educate hospital liaison committee members. And these members are the ones that's working with the witness community to continue to be an advocate for them and to continue working with the providers to educate them on non-blood management strategy. So they're very much involved with making sure that we have reliable resources, facilities, and doctors that will be cooperative.
And Joseph and I and others in our team, we just traveled to the Watchtower about 2 weeks ago. We want to make sure we're meeting the needs of the population. We want to educate them on any new strategies coming in to assure that it's acceptable. And as Joseph mentioned, this is a very tight-knit community. They're aware who their elders are in terms of HLC and HIS. And there's a lot of good information that the Watchtower puts out, both online and publications, to educate the population on what all this means in terms of blood product support.
Great, thank you. Next question we have, how do you handle situations when a family member disagrees with the patient's bloodless preferences? And I'm assuming we're talking about a competent adult here.
So we'll go from both sides. I'll go first, Joseph, if okay. So we want to make sure that this is, that we're engaging the entire family or friend unit along with the patient. So it really is making sure that we're not doing separate conversations necessarily. We want to engage everybody. And from my standpoint, I'll go from the physician or provider standpoint first, and then Joseph. So we're very devoted, for me, not to insist somebody take a blood transfusion, and for Joseph, on the other hand, not to insist that they don't have the right to change their mind. They can. And how often does someone change their mind? It is extremely rare. Maybe 1 in a few hundred patients will reverse their decision if it's life-threatening. So we really bring the whole family in, and it would be, the analogy would be if you had a do not resuscitate and the family members disagree with that, how would you manage that? It really is bringing the whole family in, allowing them the opportunity to better understand autonomy and competency in the adult and respecting that. So it is a lot of discussion, counseling, and engaging the whole family unit. And then we also want Joseph and his team to be involved.
I think also additional part of that is we really try to support or to advocate the importance of respecting and valuing differences. Particularly, we've had cases where there was a husband and wife team, and the wife was very adamant about not wanting to receive a blood transfusion, but the husband felt quite differently about that. So what we really try to do is to make sure we ask the family members to just sort of put themselves in the position of the family member or the patient, and do to them as they would want others to do to them. So therefore, we advocate for them to just respect and value the differences. And if the tables were turned, they would want their spouse to advocate for them for according to their wishes and not what we would personally want.
Thanks. So similarly, on the same topic, how have you dealt with healthcare providers who are having moral distress about these types of decisions, and how having to care for a patient that perhaps they, is that part of the education that I know you mentioned several times that you have an extensive education? Is that something that you work with or have resources for people who are struggling to deal with some of the decisions that are being made?
So I think the first thing is, as we have new providers come in, the team does meet with them so that they can better understand this population and give them the ability to decide for themselves ahead of time. Would you be willing to care for this population? And part of that is also discussing all the support that is available here from the coordinators, from the HLC, from myself, to provide care for the patient clinically. So we do have a 100% at this point, physicians say, yes, we would be willing to care for these. Now, we never force. So I'll give you an example, a recent one. We're a big, University of Penn's a big health system. We're located at one of the smaller hospitals, Pennsylvania Hospital. At the larger academic center, in my 20 years, they have never been willing to offer a kidney transplant to a Jehovah Witness. I cannot force them to do that. They have to be in their comfort level. But more recently, two providers came in that had transplanted one Jehovah Witness each, and they said, we want to rethink this. So we're developing a whole support system, protocol, pathways, et cetera, to allow them to open that up to that population. I get phone calls all the time. And the way that I handle the phone calls is because the physicians, we see 1,000 patients a year, but maybe they only see one in their whole career, or just a handful in their whole career. So the first thing I do there for physicians is mostly they're very afraid that the patient is going to die and that somehow they're going to be liable for that. So they don't want to provide the care. So we try to transfer them to us. We don't want them to be in a facility where you're not comfortable treating them. And we have more strategies we can use here, more expertise anyway. If I can't transfer them, it's somewhere else in the country, then I will walk them through this. And we will also help with discussions with the patient and the family, even though they may not have the same forms as us, but we'll help them understand what they're allowed to take or not. So the HLC has my private phone number. I can be reached at any time to put forth discussions with providers. And most of the time, it's not their unwillingness, it's just their fear that patients are going to die because they don't have the expertise or the knowledge to take care of them. So hopefully our counseling them helps. Joseph, anything you wanted to add? Yeah.
Sure. I think it's a wonderful thing to know that the provider has such great concern and they feel like they have a valuable resource they think could be helpful. But I think it's important for the provider to remember or to be reminded that the patient is making a conscientious decision. They're making it very clear that it's their desire to live, yes, but they would not give consent to use of blood, even if their life depended on it. So the patient is willing to accept the ramification that comes with that decision. So that's hopefully takes some of the burden that lies on the provider.
Okay, great. This webinar will be ending soon, but we do have time for a few more questions before we end the program. So if you do have any questions, please go ahead and place them in the chat box. We have another here. What are some common missteps healthcare providers can make when caring for Jehovah's Witness patients, and how can they be avoided?
I think if I had to pick one, it would be assuming that the patients understand all of these blood products. So they don't. They just know they can't take blood. This is one small aspect of their religion. It is the biggest one for us as healthcare providers, but it's one small aspect. So I think that to me would be a misstep to hear, as you saw in one of our case studies there. You can't assume that the patient understands what all these products are. That's why we have the coordinators 24/7 to figure that all out for you and make that checklist. And vice versa, I don't expect providers to know all these things, such as what are the 4 components they can not take, what else can they take, what are other strategies. So it really is that misconception that either one of the providers or the patients really fully understand this.
I would say also for the provider to allow their personal preferences to interfere with their medical decisions, because we know this are very emotional things, perhaps sometimes, but it's really important that the provider remember the importance of respecting the patient's position and not badgering the patient in any way or expressing their own personal feelings and opinions about the patient's decision.
Great. You had mentioned previously in the presentation, on one of the slides, I believe there was a sign that had minimal blood draws as part of the care of this patient. Is there, when you are having a Jehovah's Witness patient in general, regardless of what they're in the hospital for, is there a specific protocol related to that where they would not maybe have as many blood draws, or how would a provider know that that's, you know, like if there's an appropriate amount of times? Is it just the minimal amount that's required?
And so it can be either volume or number. So a volume could be the use of pediatric tubes, or even in your regular tubes, drawing only the amount, don't overfill. But it is related more to the number of phlebotomies. So think about a teaching hospital. In the morning, everybody gets a blood draw, whether they need it or not, a CBC and a chemistry. Everybody gets it. In the ICU, you get multiple things during the day. So it's rethinking. Do I really need a CBC every day? Do I need that chemistry if it's been normal for 3 days in a row? Do I need repeat cultures every time there's a fever?
So it looks like we're at the end of our time. Thank you both so much for this amazing information. We appreciate it. There's great comments in our chat thanking you both for the information you provided today. I'd like to thank everyone for joining us today. If you experience any issues accessing the evaluation or certificate of continuing education, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov. And this concludes our webinar. Thanks, everyone. Have a wonderful day.